Does it hurt when you're swallowing? Does it hurt on one side of your throat? It could be caused by several diseases, and we will get to know one of it. Peritonsillar abscess. Let's get started. A peritonsillar abscess is a bacterial infection that usually begins as a complication of untreated strep throat or tonsillitis. It generally involves a pus-filled pocket that forms near one of your tonsils. Peritonsillar abscesses are most common in children, adolescents, and young adults. They often occur at the beginning or end of the winter season, when illnesses like strep throat and tonsillitis are most widespread. The pathophysiology of PTA is unknown. The most widely accepted theory involves the progression of an episode of exudative tonsillitis first into peritonsillitis and then into frank abscess formation. Those who suffer from peritonsillar abscess usually have these symptoms: increased body temperature. Infections cause most fevers. You get a fever because your body is trying to kill the virus or bacteria that caused the infection. Most of those bacteria and viruses do well when your body is at your normal temperature. But if you have a fever, it is harder for them to survive. Fever also activates your body's immune system. Odynophagia is defined as a painful sensation in the esophageal region that occurs in relation to swallowing. Swallowing becomes highly painful for people with peritonsillar abscess, resulting in pooling of saliva or drooling. The muffled voice, also known as hot potato voice, is pathognomonic of quinsy. It indicates a space-occupying lesion in the oral cavity or oropharynx. Having enlarged tonsils due to acute tonsillitis, tonsillar hypertrophy or tumor can produce similar symptoms. Trismus. The inability to open mouth of varying severity occurs in almost every case due to inflammation of the pterygoid muscles, which lie near the superior constrictor muscles. Other accompanying features include fever with rigors and chills, malaise, body aches, headache, nausea, and constipation. For further diagnosis, the following test is required. Complete blood count. This test usually shows leukocytosis, which really help a lot on diagnosis. It is frequently a sign of an inflammatory response, most commonly the result of infection. Heterophile antibody test. This test is required to rule out suspicion of infectious mononucleosis. Pus culture sensitivity from needle aspirate of the abscess. Contrast-enhanced CT is required in a very young patient where clinical diagnosis or in cases with other complications like the development of parapharyngeal or retropharyngeal abscess is not feasible. Intraoral ultrasonography is a simple, non-invasive imaging modality proposed to differentiate peritonsillitis from a peritonsillar abscess. Another important use is in the exact localization of site for abscess drainage. Still with me? Good. Now we're going to the not-so-good part of a disease: the complications. If not treated accordingly, the peritonsillar abscess could lead to these following complications: parapharyngeal abscess, retropharyngeal abscess, laryngeal edema leading to airway compromise, rarely pneumonia or lung abscess following aspiration of a ruptured abscess, or even sepsis. A suitable intravenous antibiotic is started. The antibacterial spectrum should include gram-positive, gram-negative, and anaerobes. Commonly used empirical antibiotics are penicillins like ampicillin or amoxicillin in combination with metronidazole or clindamycin. A patient is shifted to oral antibiotics once he improves and can tolerate orally. Analgesics and antipyretics are given to relieve pain and fever. The role of steroids is controversial. A study shows that a single dose of intravenous dexamethasone reduces the hospital stay and severity of symptoms. These conservative measures can cure peritonsillitis, however, for peritonsillar abscess, drainage is a must along with medical management. In most cases, peritonsillar abscess goes away with treatment. The infection may return in the future. Now we already reached the end of the video. Let me summarize what we learned today for you. Peritonsillar abscess is localized collections of pus in peritonsillar space between the tonsillar capsule and superior constrictor muscle. Since this space is composed of loose connective tissue, it is highly susceptible to abscess formation following infection. The most common bacteria that caused a peritonsillar abscess are aerobic bacteria. The symptoms of peritonsillar abscess are increased body temperature, odenophagia that cause drooling, hot potato voice, and trismus. On examination, the patient is usually ill-looking and febrile. Clinical presentation may vary from acute tonsillitis with a minimal unilateral pharyngeal bulge to dehydration and sepsis. The tonsil is found pushed downward and medially, it blanches on applying slight pressure. The uvula is swollen and edematous and pushed to the opposite side. The antibacterial spectrum should include gram-positive, gram-negative, and anaerobes. Commonly used empirical antibiotics are penicillins like ampicillin or amoxicillin in combination with metronidazole or clindamycin. Thank you for watching this video. Hope you learned something new and interesting. I realize that this video is very far from perfect. I hope we can make something much better in the future. See you on the top.